Good afternoon, everybody. Thank you for all coming back. We're going to try to get started promptly for the second afternoon session here. And I have the pleasure of introducing Dr. Cassandra Craig. She is a wonderful gastroenterologist that practices at Wilford Hall, and that I got to work with her briefly at BAMC, and she'll be talking with us today about chronic diarrhea.
Okay, can everybody hear me? Is this working? Yes? Okay, wonderful. So they put me at the end of the day. Who likes to talk about chronic diarrhea? Are you guys experts on chronic diarrhea? Are there good guidelines on chronic diarrhea? Anybody? No, there's really not. So I'm going to tell you my approach. I am a young gastroenterologist. This is what I have practiced in the last 4 years, kind of my model, different guidelines I brought together, what I think, what I do in my practice. I would love if you guys are engaged. Please do. Say what works for you. We're going to focus mostly on how to cluster things, and then at the end kind of go into some of the management as well. Stop me whenever. I'm going to give a shout out. If you guys have never met Dr. Carl K., he's one of my idols, and he was my fellow. But he taught me QR codes, and these ones have the cute little monkeys on them and everything, which I thought was adorable. I did put them up. This is the first lecture I've ever given that actually had QR codes on. So it, I think, succeeded. I used my phone to make sure it worked. What I was trying to do is give you a picture of all the kind of puzzle pieces that I use when I'm trying to approach this with my patients. So the one on the left, this is Dr. Schiller and his colleagues who wrote this one, Chronic Diarrhea Diagnosis and Management. I love this one. This is how my brain works. I was a math and engineering major way before I was a doctor. So this is how my mind can wrap around chronic diarrhea the best, but everybody's different. On the bottom is the gut one, so the Brits published that one. It's not quite as much what I don't know, I can't approach it as easily when I'm trying to think through my patients in a busy clinic, but I think it's great and it has a different way. So we're gonna go over that one as well. On the top one, you can't talk about chronic diarrhea unless you're also approaching there's a functional part of it too, right? So whether you're talking about just chronic diarrhea as its whole entity or you're talking about the functional diarrhea and IBS-D component. So those three we're all gonna kind of focus on. This is actually not gonna be a lecture where you get 500 references at the end, so you're welcome. This is actually just gonna be what I really like to use. So there's like 7 references, that's okay. I don't think you need to know about everything, I think you need to know how to approach it. Okay, so this is what we're gonna get through. This lecture should not be super long and painful. I thought at the end of the day at like 3:30 we might be really behind, so this might not even take the whole 30 minutes, so hopefully that gets you guys excited to begin with. But this is what we're gonna get through, okay? Okay, so that top guideline, that AGA guideline, that was the functional diarrhea IBS-D. Who can you use that for? Does anybody actually want to like jump up and help me on this lecture, or is it gonna be like me continuously asking questions you guys don't answer? Give me a sense of my crowd today. Are you guys talkers? I'm gonna talk a lot. Okay, well I got to sleep in today and I got to practice for my triathlon, so I'm like endless energy right now. So I'll just keep the talking going. So who can I apply these guidelines to? If we're talking about functional diarrhea, part of chronic diarrhea, functional diarrhea, it has to be watery diarrhea, it has to be 4 weeks, okay? You have to have a properly working immune function. If you do not have your immune system intact, then we are not talking about these guidelines to help you with your patients. And it's going to exclude all these ones below. In general, how do these last 5 symptoms or these last 4, what is that? It's your red flags, right? So if they have red flags, if they do not have greater than 4 weeks, if they do not have a properly working immune system, you cannot apply these guidelines, okay? And I think that's the first thing you need to take to step back, because we're not gonna talk the majority of the time about this guideline, that's for that reason. But understand there's a place for it. Okay, so with that, I wanted to step by step go through every single recommendation they put in this guideline and actually read them aloud. Can I get anybody who likes to talk in the class, in the front, who can read these? Anybody willing? Will you, please? Just read them, yes. Or is it too small? I can read it if it's too small.
Fecal calprotectin or fecal lactoferrin is free for IBD.
Okay, so recommendation 1 for the AGA guidelines, if we're talking about functional type disorders, they do recommend doing fecal calprotectin or fecal lactoferrin. Are you guys doing that in all your patients who are presenting with these? Great. That one I think most of us are doing. What I'm also finding most of us are doing is then shotgunning every lab known to man on these patients, and that's what we're not supposed to be doing. So let's get through the rest of them. All right, thank you for doing the first one. It's probably pretty tiny for you, I'll do the rest. So do not use ESR or CRP, okay? Do not use ESR or CRP on these patients. Do test for Giardia. Do not test for ova and parasites unless you have a travel history that says you should. Do test for celiac disease. Choose your test that you want to use. Here they put the IgA, TTG, second line test if you're IgA deficient. Do test or empirically treat for bile acid diarrhea. Just by show of hands, how many people can test for bile acid diarrhea here? Yeah, exactly. You can. So most people are just going to empirically treat. And then no recommendation to use the serologic IBS test. So how many things in here are we actually supposed to be doing for these patients who have no red flag symptoms, who have 4 weeks of diarrhea, who are not have a competent immune system? There's not a lot, right? We're supposed to be screening for celiac disease, screening for potential IBD, but past that, you're not actually supposed to be, I'm going to now do 24-hour fecal fats, and I'm going to be doing this and every exotic thing that I've ever seen. Or for us in the military, because I'm military, go into Genesis and be like, stool test. What are all the ones that come up? There's like 100, right? We're not supposed to be doing that for these patients. These guidelines, though, are only applying to that subset that we just identified on the first slide. What about food allergy and sensitivity testing? Are you guys having a lot of patients show up with a sheet that is being given to you? What are you doing? The people who are nodding in the crowd. What's your answer? Anybody? Throw it in the trash. Okay, great. So we throw it in the trash. What else? We take off the name, scratch it out, and then be like, okay. Anything else? Do you guys know what to do with them? I certainly don't. I mean, I feel like once a month, I try to look this answer up. I'm like, I have like a search in PubMed that's like constantly refreshing, being like, there's gonna be an answer next month. I know there's gonna be an answer. This is gonna be awesome. I have something to tell my patients, so it's gonna look like I have an MD behind my name and I know what I'm doing. No, I never do. So what are they still saying? They're saying that if you have a cause and effect, I eat this food, I get sick, I have these symptoms, then send them to allergy and get allergy testing, right? But we have nothing to say that we should do anything else. So with that, that's what I tell my patients. I'm still telling my patients, I appreciate your results. Thank you so much for bringing this in. I'll have it in your chart, but I can't really make guidance for you guys. I can't give you recommendations based on this. But what I do say, and I've always told my patients, my mom taught me this actually, is the patient is the expert. They know their body better than you, right? I know they're the expert. So if you say, I eat this and it makes me sick, then stop eating that, right? I don't care if there's a test for this. Don't stop eating everything, please. The people who are like, I've cut out 800 things. I'm like, well, you're gonna die. But besides that, if you don't feel good after you eat something, then stop eating it, right? So I still do that with my patients. I say, you're the expert. You are in charge of your health, and if you say these things make you sick, then please stop doing them. I can give you low FODMAP diets that I have a little bit better evidence on. I can tell you ways to tailor this and try to not go crazy. Because I also have patients who come to me and we're like, I'm obsessive, basically, about my diet. So this is what I tell my patients to this day. Okay, to call it IBS or not to call it IBS. We all know the Rome criteria, we're not gonna go through that. Patients without alarm features who meet criteria, should they get other testing? What other testing do you consider doing? Anybody? Just everybody still just kind of like test for everything because the patient's sitting there being like, but I'm sure I'm dying, so I need to check for everything. So I did want to bring up this. So on the bottom of this, under the exceptions, I like to give this data to people when I'm talking to them. So celiac disease, right? So patients with meeting criteria for IBS, a lot more of them are going to have celiac disease in the end. So if they meet criteria for IBS-C, it does not mean that you should not be testing for other things. Importantly, now remember on the AGA guidelines, testing for celiac should be part of your algorithm, but what's not in that algorithm? Checking for microscopic colitis. And they actually, when they scope these people, there is a higher rate of microscopic colitis. So choose the right people. How do I do that? I pick the demographic, right? So I look at their meds. I will tell you it's getting harder and harder to find a patient who's not on a PPI, NSAID, or an SSRI. So that's making it a little bit harder for me to tailor down who I'm gonna send. To be fair, at this point, if it's a female on those medications and they have profound symptoms and they're not getting better on Imodium, because truly, what is the first line treatment of microscopic colitis anyways? It's giving antidiarrheal, right? So I'm not going to scope every person, although I love scoping. I'm not gonna scope every person, but if they don't respond to Imodium and they're in the right demographic and they're on any one of those meds, yes, I will make sure they don't have microscopic colitis. Make sense? Okay. So how do you define the problem when it comes to you? I like putting this up. It actually was in one of the first pages in Dr. Schiller's lecture, but it very nicely, I remember being intern year, resident, I don't know. I was somewhere in my many years of school where I thought like, oh my gosh, I got this wrong all along. I thought I knew what diarrhea was. And then I realized that we kind of define it differently than our patients, right? So how do your patients define it? Does anyone want to throw out? What are all the things they come in saying that they have diarrhea? Loose stools. How about the one who's like, I go 10 times a day? I'm like, cool, when does that happen? They're like, well, 1 minute in between every stool, and I actually have like this much that comes out, and it's all in the morning, right? So that's describing something different to me than it is to them. So I like talking to my patients. You guys will get a feel for who I am as a person from this lecture, but I do like talking to my patients. I enjoy it. I enjoy scoping, but I also like my patients. I just let them talk. Like, you go. Like, you have 40 minutes with me. I'm blessed in the military. I have 40-minute spec appointments. So they can just talk and tell me what they think. I know, I'm sorry. I do get a lot of time. And I have fellows with me. But so I get to just say, what do you guys think is going on? What is bothering you? And then once I let them get their 5 minutes out of what they think diarrhea is, then I go, okay, great. Let's talk about how loose they are. Let's try to get an objective idea of what is going on. Because you can start to cluster them based on, you let them talk, and now you understand, is it really that they're having large volume loose stools, or is it that they're going to the bathroom and not completely relieving themselves? What is going on, right? So I let them talk first, do all their talking, maybe less talking if you don't. What is the average like spec length for people in here? Not 40 minutes clearly, so what is it? 15. 15 for a spec? Oh my God, what do you get for a follow-up? 15. You get the same time for a follow-up as a spec? Oh my gosh. You can come work for the military. You can come join me. It'll be fine. Okay. Clustering. So this is how my brain works when I'm trying to think about diarrhea, is I start to put it in clusters, and that's what we're going to go through for the majority of this. My slides are pretty simple. There's not going to be a whole lot of words and jargon. Like I said, I think those 3 QR codes is where I get most of my information, where I can conceptualize this. We're going to talk through most of it. So there's the functional side and the organic. So who is functional, right? Your IBS and your functional diarrhea, once again, they have to have a normal immune system, and they cannot have red flag symptoms. That is now in the functional. Or are we talking about something organic? So that's one way to look at it. This is something that you really need to do early on, right? So the patient has come in, you've let them talk for, it sounds like maybe 30 seconds is what you guys have time for. So you gave them their 30 seconds, and then you immediately, remember like the med student was supposed to go in there and listen and not ask questions? It sounds like that does not work if you have 50-minute appointments. So you immediately jump in and you're like, okay, I need to know all these questions. Have you had fevers? Do you have abdominal pain with this? Are you having fatigue, night sweats? And these are big categories, 4 different things that you can start to break them down into, right? Big categories. Because the right answer is not actually for chronic diarrhea to check every single lab and do a colonoscopy and do this all on the first day, right? So do I have an inflammatory looking condition? That might be somebody reasonable to go pretty immediately to an ileocolonoscopy. Do I have a carbohydrate, more malabsorptive picture? Are they having primarily gas and bloating, or is this more just loose stools? Lymphoma, a little bit less rare, but am I going down the fatigue, night sweats, any of the class B symptoms, or cancer? And do I need to be going down? I should scope them sooner rather than later. Okay, so that is symptom cluster. What about the stool? And I think this is the one that, once again, maybe you guys will not have the time to get into all of this, but if you do, this really matters, right? Is it that they have the urge to go? Is it that they have the urge to go and they go, but they don't actually ever feel like they've completely evacuated their bowels? Is it that they're having pain or rectal pain when they're having the bowel movements? Is this looking more like a proctitis picture, right? Is this something lower down? Or is it a small bowel source? Those 2 should not present the same, right? If you talk to your patient, these 2 first ones on the left should not be tricky to tease out, meaning you do not need to be considering both of these at the same time, most of the time. So small bowel source, less frequent, larger volume stools, should not have tenesmus. And then fat maldigestion, is there steatorrhea involved with that? I do say, do you guys have as many patients who tell me all my stools like float in the toilet bowl? Yeah, I've stopped asking that and just let them present that information to me, because like once I ask it, it's like everybody says yes, and then I want to not see pictures of their stool, which generally they have for me. Okay, so epidemiologic. So we talked through symptom clusters, we talked about what kind of bowel movements are they having, and now we're talking about, are there any associations, right? So clearly, immunocompromised patients, we're going down a different path, whether it be you're talking about HIV-associated diarrhea with different medications they're on, CMV, whatever it might be. they're somebody who is a cancer patient and on meds, that can definitely point you down a different direction. Travelers, military, we travel a lot. So that's usually like 1, 2, and 3 is like, where have you been TDY, where have you deployed, when did you deploy, and go through all that stuff. History of constipation, overflow diarrhea is very, very commonly missed. That is something you want to hear about now. And then history of diabetes or weight loss attempts, mostly just because so many patients are ingesting so many things they do not tell you unless you ask them. I had a patient the other day who was like burping in front of me like the whole time. I was like, what is going on? They're like, oh, I just have some gum, let me throw it out. I'm like, how often do you chew gum? They're like, oh, all day long. Like from the second they woke up to the second they went to bed. So not only did they have all these fake sugars, but they also were swallowing air like all day long. They stopped chewing gum and they were fixed and they never came back. Role of diet. Let's go through some of these. Fructose. Fructose and lactose really, although they more harp on the fructose side of things. So are we meant to digest large amounts of fructose as humans? Do you guys know? There's a cap for everybody. Like you will eventually reach your limit of what your enzyme can do to break that down. So understanding going through some of these with your patients and saying like, are you fruitarian or whatever you call it, where that's all you're eating all day long, this might be a significant trigger for them. Lactose is very, very common, right? I very much like, we don't use a lot of the fancy tests most of the time these days. We don't have them at Wilford Hall where I work. So for me, I just say, here, let's try lactate and see if you get better. Give it a couple weeks. If you do, now we can talk about cutting out some of these. Sugar, alcohol, malabsorption, as we talked about, short bowel, pancreatic insufficiency, food intolerances. Once again, I do not use the fancy tests. I defer to my patient, but I do spend the time with them the first time to say, what makes you feel good? And I actually will look at your food diary. I don't know if you guys actually have time for that, but I will. If they message me their food diary, which by the way, not many people actually want to do it. So I think if you took the time to do a food diary, I will take the time to look at it for you. I've never said no to them if they bring me one. There's some really crazy looking food diaries, but if you actually want to sit there and go over, spend the time, I will look at it. So I put that on the patient. I'm not gonna sit there and tell you every single trigger that might cause symptoms, but if you write down what food you ate that day and what symptoms you had, we can go through it together. And then there is still that small proportion that do have food allergies. I specifically put this one up there. There's some great graphs both for fructose in vegetables, even for like lactose-containing products, just to start breaking it down for your patients. But understand that there is a limit for everybody. If you eat all these things all the time, you generally will have some diarrhea and some bloating. What about medications? Once again, you guys love doing med recs, right? And like painfully of your 15-minute appointment, spending 14 minutes going over how many medications they're taking. Unfortunately, whenever I do this, which I try to do most days, every patient is on a medication that causes diarrhea, right? I can't get everybody to stop them. So my spiel, and take it for what you will, but how I approach it with my patients is there's a quality of life choice that you have, right? And if food is your happy place and you do not want to stop eating these foods, I cannot promise you I'm gonna get rid of all your symptoms. Vice versa, if you cut out every single thing you eat in life, probably not the greatest quality of life. And then there's somewhere in the middle. And I have that conversation on day one that I'm probably not gonna get you to fixed unless we meet somewhere in the middle. Because we do know that a lot of medications and a lot of foods are going to cause diarrhea, right? So if the SSRI is instrumental to their quality of life, then yes, they're not gonna wanna go off of that, and I get that. Can we get them to the lowest tolerated dose? Can we change them to TCA if possible? Can I work with their psychiatrist? But can I get you better, but I might not be able to fix it? Okay, just a random potpourri of things. How am I doing on time? Okay. Radiation enteritis, up to 20% of patients will have pelvic irradiation will have diarrhea later. Understand that this can also happen at any time. So keep this in mind. Very common miss is that you don't think about this. My clue is, okay, they had cancer in their diagnoses. Let me go back and figure out on day one how they were treated. If they had any irradiation, up until really a decade later, you can now have your first symptoms. And I had a couple of those patients in fellowship. The risk factors are gonna be your tiny patients, the ones who've had surgeries on their belly as well, how much radiation they had to get, and then if they had to get chemotherapy at the same time. Post-surgical diarrhea. Do you guys see many patients with vagotomies these days? No, but my staff who taught me definitely did. I had a pretty elderly population of staff who taught me in fellowship, and like that's all they talked about. They're like, well, those vagotomy patients. I'm like, well, I've never seen one, but they did. They had all these older patients who had vagotomies back in the day before PPIs were big. And so that is absolutely something that you want to keep an eye out for. It's not something you see as much anymore. Bacterial overgrowth, abdominal surgery is definitely going to predispose you to this. All the etiology of this is a little bit boring, but thinking about it, diarrhea by bile acids, do you guys know how that happens? Has to do with, okay. So keep in mind that these two work together. So look at this for your patients with small bowel bacterial overgrowth. Let's go to the last one, the short bowel syndrome. Mostly in your IBD patients, complicated surgical patients. We do have some wicked trauma patients at our hospital, so if they did have a large amount of their small bowel removed with their trauma, something to keep in mind. I put this up here just for you guys to have for reference. A lot of the times we are not going to be doing 24-hour stool weights, but this is a nice way to break it down if you're looking at, okay, I have a smaller volume stool, what are the things I need to be looking at? I have diarrhea, what are the things I need to be looking at? It's an osmotic type of diarrhea, what should I be looking at? So I'm really just going to leave it there for reference for you guys. Okay, what do you guys do next? Everybody gets a colonoscopy, because that's what people come in wanting? Hopefully not. Okay, let's talk about the blood tests. I'm going to get a CBC to CMP on all my patients. I'm going to get celiac testing on all my patients. I'm going to get a fecal calprotectin on all my patients when they're coming in as well. And then depending on the patient, I will likely get a TSH when they come in. More specific tests, depending on the patient, targeted towards them. So those are really like the 4 to 5 tests I'm going to get on all my patients to begin with, are the top ones. The hormone-secreting tumors, power to you if you've found many of them in your career, but they're really not common, so this is not where the path you should be going down on most of your patients without the right clinical history. What about imaging tests? Are you getting CT scans on every single person with diarrhea? Hopefully not. Okay, so if they have anatomic abnormalities that you are specifically trying to tease out a little bit more, if you have a patient with IBD, that might be a reasonable person. In that case, I'm probably going to be going for an MRE or a CTE rather than just a non-con CT scan. If you have a patient who has risk factors for chronic pancreatitis, once again, go to something more specific for that patient, whether it be dedicated pancreatic imaging or if you need to do something else endoscopic in EUS to stage it at that point. And then hormone-secreting tumors, keep in mind that these are not going to just be standard go send for a CT scan. So there should be very, very, very limited times we're ever going to send patient just to get a CT scan for chronic diarrhea. Very limited. What about endoscopies? So I put this up here on the right just to show you that 15 to 31% diagnostic yield for colonoscopy for chronic diarrhea. So there's actually a lot of patients that are going to have findings. To me, if 31% are going to have microscopic colitis or IBD or fill in the blank, I think that's pretty reasonable to go down that path. Now that's, once again, if a patient's not getting better with conservative measures. You don't need to do this on everybody. Upper endoscopy, about 8.6%. I would say that that's probably not quite as relevant if you've already done the celiac testing and identified a lot of them just based on their serologies. And then talking with your pathologist. That is on me when I'm putting in the path. I am usually pretty specific in what I give the pathologist so they know what I'm looking for. And very commonly, if I get my report back and it just doesn't smell right, and it was not read by a GI pathologist, then I will ask for a second read from a GI pathologist, because there's a lot of second reads I've gotten back that had the answer. So just keep in mind, when you're seeing them in clinic, if there's things that you're thinking about from their history, please let us know that in the order, because the person doing the procedure should be putting that in their path request. What about the physiologic tests? Breath tests, people do them. I'm not really doing them anymore, but we don't have access to that. I can't say it's affected my practice that much because I did used to do them in fellowship. I'm very much a fan of, can I, in a non-invasive way, be testing for this? For lactase deficiency, that's not hard at all, right? You can give them, either have them withdrawal milk or any lactose-containing products, or you can just give them lactate and see how they do from there. Gold standard is still going to be doing intestinal aspirates. We did do those at Travis where I was working before. They were pretty painful just because you can do them wrong very easily, but they are still options to look at. And we're going to go through this, just understand that idiopathic bile acid malabsorption can be, it is there, and it's something you should be thinking about with your IBSD patients. So I'm very commonly going to be treating them for this. I use cholestyramine quite frequently, actually, just as a trial, but I will do it just the once-a-day dosing. I do not need to make it impossible for my patients. I also feel like it's pretty hard to find patients who are not taking something they'll interact with. Case in point, I had a patient just a couple of days ago, their birth control, and they had a really hard time wrapping their head around that they had to separate their OCP from their cholestyramine. So, as I did not want them to accidentally get pregnant, as that was not their wish, we just went to a once-a-day dose, and we're going to give it a couple weeks, and they're taking them very far apart. But Then pancreatic function testing, gold standard is still doing the secretin stimulation test. You do have some other tests that you can do with your stool, but empiric treatment is most likely what you're going to be doing. And also keep in mind that it's the right clinical history. It's knowing the right patient who has those features of chronic pancreatitis. Okay, I know this is busy. I wanted you guys to see it though and be able to take a picture if you wanted. Frequent diagnoses in patients with diarrhea of obscure origin, right? So these are most of what you're going to see. I would argue that the surreptitious laxative ingestion, that was on there. I can't say that I'm really hunting for that. If you're taking laxatives and having diarrhea, just stop, yeah. And if you don't want to stop, and I don't need to tell you that based on a test, but diabetic neuropathy, microscopic colitis, I am scoping a lot of people and finding this. Actually, interestingly, I had a couple patients recently where their colon just kind of looked just a little off. I was like, man, the vessel pattern's not quite right. And I was like, I think that's gonna be microscopic colitis. And both of them came back with microscopic colitis, which is interesting to me as it's microscopic colitis. But the mucosa definitely did not look quite normal, and it did come back that way. So I am biopsying a lot of my patients now. Iatrogenic diarrhea, either from drugs, surgery, radiation, something else. Fecal incontinence, that's a big one that I think we miss, and be worth sending to your motility folks if you need to get more objective evidence. And then carbohydrate malabsorption. Okay, I'm just putting this up here so you guys can see a different approach. Like I said, this is how my brain works. This is what works for me. This is what I want to pull up when I'm with a complicated patient and say, like, take a step back, stop being overwhelmed by the many words coming out of this person's mouth and just think, okay, can I cluster with symptoms? Can I cluster with where they've traveled? Cluster it with risk factors and start to put it into boxes, and that helps me when I'm getting overwhelmed. The Brits do it a little bit different. They have a pretty standardized, there's their primary clinical assessment, and all the things were spelled a little different. I changed some of them. Some of the labs weren't quite congruent with ours, but they actually get fits on every patient, if even in that early assessment. And they said consider fit, but then they basically said they checked it on everybody. So that's not something generally we would be doing. And they were talking about, celiac suspected. They had a pretty low threshold to suspect it and getting EGDs and not just doing celiac serologies. But they have their primary assessment and their cancer assessment, and then they go into this, which is their secondary clinical assessment, looking for common disorders, malabsorption, and they kind of break it down that way. This is a different approach to it. I like I said, to take a step back and go, I'm going to think of every patient in boxes, and which box am I going to put them in so I can focus on that. But this is definitely a valid approach as well, and that's in their gut guidelines that they published. But I did like this, and that's why I wanted to include it, is they have the common causes, the infrequent causes, and then the rare causes. So back to the common causes. So they list out, and I think that was a nice way to put it, right? If you're sitting there going, I don't have any idea what's going on. I can't even listen to what Cassandra Craig said and put it in clusters because this patient makes no sense at all. I'm overwhelmed. Where do I start? Probably start with the common causes, right? If you feel like you're getting nothing from the history and you have nothing to go off of, then stick with what's most common first. Then go to your infrequent ones. Does anybody need a picture of this before and then the rare causes, right? Probably don't start at the bottom. Probably don't start at the rare causes. If you feel like you're getting nothing from this patient, I feel like sometimes my instinct is I'll just check everything. That's not actually what we're supposed to be doing. So start at the common ones and go from there. Okay, last one, the approach to therapies. The initial approach is always gonna be your opioid agonist or your opioid agents, which is gonna be your Imodium, Lamodal. And if you cannot get your benefit from that, be thinking, should I be trying a bile acid agent as well? And then the next slide, though, is going through what if I have something to target? And I did like the way that they put this. This was actually in Dr. Schiller's article as well. So is this a bile acid issue? Start with one of your bile acid agents. Is it a diabetic diarrhea? Do I know they have a terribly controlled A1C and I think this is what's causing it? What medications can I try for them? Is this IBS-D? Is this a small volume water diarrhea, but they have incontinence with it? Then I'm usually going to be adding on a bulking agent, like a fiber supplement to begin with. And some of the other IBS-D agents, and then your HIV. So this is just some specific drugs where rather than just throw Imodium at everybody, you can start to kind of break it down and say, okay, what is their etiology? Will this work better for them or not? That's all. I told you I'd get through fast. Questions? No? Okay, thanks guys.